Good day, everyone. My name is Jobel, and I am about to present this study on the disclosure of HIV status among cohort children enrolled in the Treat Asia Pediatric HIV Observational Database, or TAPHOD. WHO and the American Academy of Pediatrics, or AAP, strongly encourage disclosure of HIV status to school-age children ages 6 to 12 years. For adolescents, it was recommended that they should know their status, given their changing behavior. There are currently very limited data on disclosure among Asian children. Therefore, this study aims to describe the frequency of disclosure in children and adolescents and its effect on death and loss to follow-up. We define disclosure as child informed of his or her HIV or AIDS diagnosis and loss to follow-up as not having data for more than 12 months. Children and adolescents 6 to 19 years of age who initiated combination antiretroviral therapy between January 1, 2008 and December 31, 2018 were included. They were required to have initiated CART at least 12 months before the site-specific database closure date and 1 clinic visit between ages 6 to 19. Data collected until December 2019 were analyzed. We use descriptive statistics to report the proportion of disclosure and demographic, immunological, and clinical characteristics at the time of CART initiation. For the risk factor analysis, Cox regression was used to study the effect of disclosure on mortality and competing risk regression to study the effect on loss to follow-up with death as the competing event. The beginning of follow-up was from the date of CART initiation with delayed entry at 6th birthday, if first CART was before age 6. The end of follow-up could be the date of death, loss to follow-up, or last visit before site-specific database closure, or turning 19.9 years. Of those who had received care in TAPHOD as of December 2018, 1,913 met the inclusion criteria. At the start of CART, those who were disclosed were older, and smaller proportion were under the care of parents, compared with children who were unaware of their status. 42% of these children and adolescents knew their HIV status. The median age at disclosure was 13 years. Almost half were disclosed after age 12. Now you can see in this table the effects of disclosure on mortality and loss to follow-up. The hazard of death was much less, almost a third, for those who were disclosed. On the other hand, the risk of loss to follow-up was lesser among those disclosed, but this was not significant. The probability of being retained in care, not reported as death or loss to follow-up, was higher for the disclosed at 5 years of follow-up. The proportion of children who were aware of their HIV diagnosis in this study was consistent with reports in India, Ethiopia, and South Africa. We had 815 who were aged more than 12 at last clinic visit, and despite the recommendations from the WHO and the AAP, 16% of them still did not know that they have HIV. Similar to our finding, studies done in Romania and Kenya also reported that there was less than half the risk of death for those who were aware of their HIV status compared to children who were not. Likewise, the finding in a multi-center study conducted in West Africa among adolescents showed that knowledge of HIV status was associated with better retention in care. The beneficial effect of HIV status disclosure on reducing mortality was demonstrated after CART initiation and beyond age of 6 in this study. Greater efforts then to consistently implement disclosure within our cohort are needed as children age into adolescence. Before I end, I would like to express my sincere gratitude towards Treat Asia office for their valuable support, the staff and the PI of the participating sites, including the study participants, Kirby Institute for the mentorship, RITM, My Mother Institute, and those behind the Fogarty Idea mentorship program for the training that proved to be very helpful to us new investigators. Thank you.